Hello, everyone, and welcome to our MP Skills Smart Diagnosis series. My name is Dr. Obi Oji, and we're just going to talk a little bit about differential diagnosis in fever of unknown origin. So this is a topic that I find that most newer nurse practitioners and even the expert nurse practitioners that are transitioning have a hard time trying to, know what the differential is. So here it is. So we start out with the case presentation. Mr. Reynolds is an 85-year-old male patient that comes in with persistent fever. He said he has some fatigue and significant weight loss and night sweats. He reports daily temperature elevation ranging from 100.8 to 102.5, and typically this occurs in the late afternoon and evening. So I want for you to kind of pause for a little minute and think about this case. So a patient is here, persistent fevers, again, some significant weight loss. And he also said that he's lost about 12 pounds in the past few months. He has some diffuse myalgias, night sweats, requiring him to change his PJs twice every night. So this is pretty significant. What are some things that come to mind before you even continue? So pause the video for a minute and think through this video before continuing. So this will be his HPI, of course. Mr. Reynolds presents with a 4-week history of intermittent fever. Fevers accompanied by fatigue, weight loss, and night sweats. He was actually seen by his primary care, who treated him empirically with a 7-day course of amoxicillin, so clavulanate, which is augmenting without improvement in symptoms. So again, this is his past medical history. Hypertension, of course, is on medications for this. Coronary artery disease. He had a myocardial infarction about 5 years ago. And then, of course, type 2 diabetes, diagnosed about 10 years ago. Chronic kidney disease stage 3A, BPH, and osteoarthritis. And then, of course, this would be his medication history. So aspirin, 81 milligram. He's on Lipitor 40, metoprolol 50 milligram, lisinopril 10 milligram. Metformin he's taken twice a day, 1,000 milligram. Tamsulosin, that's Flomax 0.4 milligram daily, and he uses Tylenol for pain, and it's PRN. So you definitely want to start thinking about the review of systems. So what type of questions would you ask this patient while you're formulating that diagnosis? So again, fever, fatigue, you want to ask questions about how long the fever has been going on. And he kind of talked about that. Fever is worse in the evenings. Fatigue, night sweats is very significant. And he had a 12-pound unintentional weight loss over the last month. For HENT, he doesn't have any headaches, no vision changes, no jaw claudication, no scalp tenderness. Cardiovascular, of course, no chest pain, no palpitations, no orthopnea. So really everything else, respiratory, GI-wise, and GU were pretty non-significant. But if you notice the patient's musculoskeletal, he just has the diffuse myalgias, but there's really no focal joint pain. So neurological, definitely want to think about, any type of weakness, numbness, tingling, and he denies all of it. Skin, he denies a rash, no lesions or skin changes. So again, in this case, just keep in mind the patient's vital signs. So you can kind of see those. 101.8, blood pressure is 138/78, heart rate is 88. Respiratory rate is 18, and SpO2 on room air is 96%. So again, this patient just talks about mild fatigue. His HENT was pretty much normal on physical exam. Cardiovascular rate, rhythm are pretty much normal. No murmurs. Respiratory clear to auscultation. Abdominal, everything is pretty much normal. You did not really notice any joint swelling, full range of motion in shoulders and hips, no significant pain with that. And then, of course, neurological, the patient is alert and oriented. Cranial nerves are intact. So again, this is a case that you want to kind of start thinking, okay, what could be the most likely differential diagnosis? Remember that in In outpatient settings, you always want to start thinking ahead of what could be going on with the patient. And then, of course, working up this patient would be really important. So again, ordering the CBC, ESR, and CRP would be really important. These are inflammatory markers that you definitely want to start thinking about ordering. Blood culture, getting a CMP, liver function test, of course. LDH will be important to also order, get some serum ferritin or serum ferritin. Blood cultures, again, 2 sets will be really imperative. Get a urinalysis just to exclude a UTI and get a urine culture. HIV, TB, you definitely want to exclude that. And then, of course, get that ANA and the rheumatoid factor. Again, this would be some really comprehensive workup for the patient, given that the patient has been on an antibiotic from his PCP, but the fever still continues. So our working diagnosis for this case would be giant cell arteritis, temporal arteritis. And just knowing a little bit about this disease process would be that GCA affects the medium to large arteries. It does exhibit diverse clinical manifestations in both the cranial and extracranial locations. Again, the typical symptoms that you'll find would be fevers, weight loss, night sweats, and fatigue. The patients would always have a markedly elevated inflammatory markers, and that's why your ESR and CRP are imperative that you order those. And then, of course, with diagnosis, a biopsy would be absolutely important to obtain as well. So these are some differential diagnoses that you definitely want to keep in mind. Occult malignancy related to lymphoma. Again, if you're thinking that that's the case, again, remember, because this patient also has the weight loss, unexplained weight loss, and then the fevers and the night sweats. So TB, of course, would also be something that you want to consider. So with lymphoma, you're looking at elevated ESR that is consistent as well with lymphoma. CT imaging would help to evaluate for lymphadenopathies or organomegaly. Again, in lymphoma, that's really important to assess lymphadenopathy. And then, of course, with TB, you're really looking for, the common infectious causes of fever of unknown origin. Endocarditis and tuberculosis would be the most pertinent differentials on your list, especially in your elderly, the older adult patients. So one thing about this case that is important for us to kind of think about would be that most of your patients that are older, they would not present with the typical signs. So again, whenever it is that you order the labs and they come back, you want to carefully assess the lab and the imaging results. This is crucial to determine what the next steps would be. So with ESR greater than 100, then you want to have a high index of suspicion that this patient has giant cell arteritis. So again, the absence of headaches, jaw claudication, or visual symptoms does not exclude the diagnosis. So these are some constitutional symptoms that we typically would find in patients with GCA. So again, they're predominantly or sole manifestation of the headaches. The patient will tell you they have headaches. They would have the temporal pain, jaw claudication, or visual symptoms. But in this patient's case, none of that showed up. Again, the patient's age is something that you definitely want to keep in mind. So imaging in FUO would be important. So getting a chest X-ray to evaluate for pulmonary pathology, malignancies, TB, looking for cavities on the chest X-ray. And then, of course, CT chest, abdominal, pelvis with contrast would be important as well. You're really getting a CT, you're looking for occult malignancies. So we talked about lymphoma, abscesses or lymphadenopathy. And then, of course, obtaining the temporal artery ultrasound will be important as well. So again, with temporal artery biopsy, you want to arrange for urgent temporal artery biopsy within 1 to 2 weeks. If you're in the internal medicine clinic, again, giving this patient's high clinical suspicion for giant cell arteritis, then you definitely want to initiate that corticosteroid therapy as soon as possible. So the advanced practitioner should have that high clinical suspicion, high index of suspicion and risk of vision loss with giant cell arteritis, and that's why you're initiating that prednisone as soon as possible is important. So 40 to 60 milligram daily after the temporal artery biopsy. Do not delay treatment. Again, remember the risk of vision loss associated with GCA. And then, of course, whenever the lab results come back with ESR and CRP that are elevated, that would be elevated in at least 90% of your patients with both your giant cell arteritis and FUO, so fever of unknown origin. So again, that markedly elevated ESR greater than 100 narrows that differential significantly with infections. So again, you always want to think about the fact that with that, the first things first, you want to think about infections, lymphoma, and then GCA being the most common causes for markedly elevated ESR. Okay, so let's kind of talk a little bit about this, the case consideration for your practice. So in your older adult patients with FUO, so your patients that will come in with fever of unknown origin, you always want to consider that there could be two conditions. It could be an inflammatory condition or it could be an autoimmune condition. So again, in this case, this is GCA, giant cell arteritis. The patients in this age range could have really vague symptoms, making timely diagnosis critical for effective management. So we talked about the vision loss associated with the GCA. So the absence of headaches, jaw claudication, or visual symptoms does not exclude diagnosis of GCA. All right. Well, thank you so much for listening to my presentation. This is our